Alright guys, my name is Lauren Schneider. A lot of new faces in here that I don't know, so just my background, I'm also a nurse at Memorial Hermann. I started my career with neonatal ICU and then I went to pediatrics, so that's why I was agreed to teach, because I have a little bit of knowledge about pediatrics and I'm not terrified of them. I know everybody else, when we get a pediatric call, how many of you guys feel comfortable when you have a kiddo on your stretcher?
No.
Right. Everybody kind of has that moment of panic because it's different, right? And then besides for a baby or a child, you also have a family that's also panicking next to you. So you have more than one patient to always think about because the family is also considered part of your patient to consider. So we're gonna start just by going over the anatomy differences. So there's the common saying that everybody says a pediatric patient is just a smaller version of an adult. It's not exactly accurate. There's a lot of differences that we need to keep in mind when we're taking care of a child, right? Their anatomy has things that are going to make it a little bit harder to take care of, right? So pediatric airways, they have large heads, right? Babies, small infants, toddlers, their head is probably like close to 25% of their body. Like you can see them, that's why a lot of them fall over and they get head injuries when they fall because their head is so heavy and they'll fall over backwards, hit their head. Sorry. In the same respect, you can turn it off out here. Do you want lights on? Do you want it dim? Set the mood? You can fall asleep on me, it's okay. I'm a night shifter, I like dark. Okay, choose.
I don't think that one has a lot of, sorry. I'm disrupting you. Keep going.
So with a large head, the thing you have to keep in mind with, especially for airway.
Hey, just leave it off.
Keep on doing it.
Keep on doing
There we go. Awake and asleep. And awake.
Don't worry, I got it.
All right, ADD, sit down. Okay, infants with large head. So whenever you position, like a large majority of calls with pediatrics are respiratory in nature. And something you can solve really easily is just positioning them optimally. With that being said, their head is going to make them naturally want to kind of crunch forward and kind of block off their airway this way. So we talk about putting a shoulder roll under them. A lot of people think it's a neck roll, so they put it under their neck. That doesn't really help them. But if you put it under their shoulders up here, they'll lift their body up and their big head is going to tilt backwards and put them in the better sniffing position. Open up their airway a little bit better. There is the possibility that you can overflex them and you can turn them back too much. So something we'll talk about in a little bit is airway views for the paramedics here. Pediatrics are very anterior, meaning a lot of people want to crank their view or their McGrath all the way, or Miller or McGrath all the way back. And if you crank too far, you're going to actually obstruct the view by going too much. Any questions so far? If you have questions, just raise your hand and interrupt me. I don't care. So this is a good view of the difference between the different ages. So an infant, see how big their head is? We put the shoulder roll underneath their shoulders, lift up their head off the bed. Small children, sometimes they don't need anything. Sometimes you can just lift the head of the bed or the head of the stretcher up, get them to open up the airway and be in a better breathing position for them. And then older children, it's just like adults. Put a roll or something just underneath their head. Or sometimes, like I said, just lift up the head of the stretcher, and that's all you need. Something to think about for our infants that we're going to be getting calls for, not necessarily now, but something to keep in mind is flu and RSV. All of those are happening all throughout the year now. Like before we used to have seasons for them, right? And you could always be like, all right, it's flu season, it's RSV season, you're going to get the snotty kids that are sick, not feeling well. Now it's not so much. Now you can get them in the middle of the summer. You're going to get a respiratory call because mom's going to be freaking out saying baby stop breathing, or you know, they turn blue for a second. You're going to walk up to them and they're going to be like full of snot and like breathing like snotty, like breathing. Babies are obligate nose breathers, which means they depend on an open nose to breathe. So for the snotty kids that we're going to get a call for, try and suction out their nose And sometimes that's all they need. For the suctioning, we usually say to use the suction catheter, the French catheters that we have. Always, when you check off your truck, know where your equipment is, because a yonker on a baby is not going to fit in their nose. Good luck, but it'll probably cause more damage than anything. Children also have, besides for a big head, they also have big tongues. So their tongue is going to get in the way very easily and obstruct your view. So for EMTs, like if you get to a baby or a small child and you say, all right, we have to bag the baby, sometimes that tongue is going to obstruct even with bagging. So keep in mind oral airways. That's going to help move that tongue out of the way. Just make sure that when you're measuring the oral airway, you're measuring appropriately, because you don't want to put the oral airway too far down and then obstruct too far down, or too small and then it's not really doing anything. But the oral airway will move that tongue out of the way. And then for intubating, you can use a McGrath to kind of get it out of the way, but the McGrath we'll talk about in a little bit is going to be kind of difficult with the view. Babies especially will have a very, very floppy epiglottis. So when you go to intubate, we all, for adults, you use a McGrath, right? You go into the molecular space and you lift up the epiglottis, right? For babies, it's not really effective to lift up the epiglottis because it's so floppy. You will go into the molecular space because they have one, but you'll go into that space and the epiglottis still wants to just kind of flop down. So that's why they recommend using a Miller blade. The only unfortunate thing with us is you have to go direct with the Miller blade. So you just have to be really talented. So the floppy epiglottis, besides for it being just large and just falling down and obstructing your view, it's also on newborn babies. It'll be bright red, their vocal cords. All of their anatomy is going to look red. You're going to go into view, and instead of seeing white, beautiful cords, everything's going to look the same color, and you're just going to have to know what the shape of everything looks like. Cords will still look like cords, right? They're just going to be more red-toned color. And then the epiglottis will be like red looking.
One thing that Doc brought up, he said in on the first class, was somebody asked, like, well, should we start with the Miller first? Should we start with the McGrath first? And the thing that he mentioned was that he would want people to use what they feel more comfortable with, because not a lot of us are practicing using direct anymore. And then how many of you guys have practiced using a Miller lately? Like, probably not, right? So you're probably more comfortable with the McGrath, but if you're having difficult getting a view, you would want you to have the Miller out in the event that...
What I would say here is, like, McGrath is what we're trained on the best, and it's a video laryngoscope, right? So you'll have the video. Use that first, but if you really truly can't get the anatomy out of the way, like Tate said, have your Miller and your direct laryngoscope next to you, because that's your backup airway. But the problem with it is you're just not going to have anybody who can like see the airway with you to talk you through it. It's going to be you, and everything you see is just what you're going to be able to see. The other thing with a McGrath is it's a very large piece of equipment, so sometimes it just physically won't fit. Like in your preemie babies, like if we get a preemie call, or if you get a very small newborn, sometimes it just simply won't fit. Like a size 1 is sometimes too large for those babies. So then, you, like I said, have your backup equipment next to you. And then the biggest thing, do not crank back. Like even on a McGrath, like babies don't have teeth, but they have gums. And it's the same as an adult. So if you crank back on a Miller or a McGrath, you're still going to destroy their gums, and those are going to be the kids that you see in the supermarket later with like their teeth like this. Yeah. Like kids that end up in ICU or NICU and they're intubated for a really, really long time, the tube actually changes their anatomy, and their arch of their airway is actually super high like this because it forms to the tube. And then like their teeth and gums will like form around that tube also. So even though they don't have teeth, don't crank back, because you'll cause braces later. So this is an adult picture, right, Tate?
Yes, it is.
So like on an adult, we'll go into the molecular space, you'll lift up the epiglottis right here, and the epiglottis is pretty firm on an adult, so it lifts up out of the way, it's pretty clear, easy view, right? On a pediatric patient, everything's a little bit more, I don't know where I'm looking on this one, Tate.
I think the, might not
This
be,
is the tongue.
yeah, it might not be a great picture to
Yeah.
demonstrate it, but.
The idea is just that the epiglottis, like they still have molecular space, but their epiglottis is just gonna be a little bit more floppy. Pediatric patients, I think, will do great with a McGrath blade, and our scope, like everything will work fine. It's just your smaller, like your premature babies that you kind of get caught off guard, like mom precipitously delivered super fast and they're 21, 23 weeks. That's a very small baby, and a McGrath 1 probably will not fit in that baby's mouth. So
I think we have Miller zeros now.
for a Miller 0, but not,
Yeah.
yeah. Miller 0.
We don't have McGrath zeros. I don't think
Yeah.
they make those.
I-
You should have a direct blade with a zero.
A 0 will essentially fit in even your smallest babies, so that would be a good size to use. Any questions so far? If I'm going too fast, just stop me. More anatomy. Their larynx is more anterior. So like I said, your view, everything is going to be super anterior. So that's why positioning is your best friend. Because just rocking your blade back is not going to actually help you. That's just going to obstruct your view, and you're just going to see more of the back of their airway. Vocal cords, like I said, on premature infants, they're going to look red or pink. All of their anatomy, like you'll be able to see shapes and identify shapes, but everything's just going to be very pink or very red. It's not the classic white that we look for in adults. It's still very easy to identify all of the anatomy though. Cricoid, it's easy to occlude with edema. So think of airway in a child, it's smaller, right? So when we have any asthma or, not asthma, croup or allergic reaction, that airway is gonna occlude a lot quicker, which is why for allergic reactions or even croup, we try to act a little bit quicker, because once the airway occludes, we kind of are out of options. Trachea, also smaller. And with breathing, your babies are going to be abdominal breathers. So a lot of us will always look at the chest. You still want to look at your chest to assess everything on your patient, right? You're going to look at, do they have equal chest rise? Are they retracting? On babies, they have weaker muscles, right? So with weaker muscles, they're intercostal in between the ribs. All those muscles, they're going to be using them a lot more to breathe. So you'll start to see them retract, and like the skin in between their muscles will be pulling in. They'll be pulling in like above their clavicles. That would be supraclavicular. Subcostal, they'll be sucking in air underneath their ribs. So like all of those muscles are trying to help the diaphragm to get air in. But for the most part, a baby should be an abdominal breather. You'll see their stomach kind of go up and down more than their chest. Does everybody know what the normal respiratory rate for a baby is? Shout it out. Shout out guesses.
40 to 50.
40 to 60 for an infant.
Look at you. You got it?
There you go. 40 to 60 for an infant. So when you're bagging, just think it's a lot faster than what we breathe. So what I usually say is on an infant, like a newborn baby, you want to say like, give them a breath, wait 2 seconds, give them another breath, wait 2 seconds. Whereas for adults, it's a little bit longer. Pediatrics, anywhere from like, it depends on their age really. Like go off of hand tubby for their age, but because like pediatric patients range from preemie all the way up to 18, right? So that's a larger, but your babies, your infants are usually about 40 to 60 breaths. That's a lot, right? For us, they would look like they're like over breathing and hyperventilating. On pediatric patients, something to keep in mind is your functional residual capacity, which is the amount of air that you have left over at the end of a breath. So say you exhale as much as you possibly can. Whatever is still left in your lungs is your FRC. With kids, they desaturate very quickly because they have less FRC. So what you want to keep in mind is you want to pre-oxygenate. Like if you have time, you want to pre-oxygenate before you intubate. And when you intubate, give yourself true 30 seconds. Don't be that person who's like, no, I see the view, I'm almost there, no, I'm almost there, no, I'm almost there. Because the problem is kids will compensate with their heart rate then. And their heart rate will initially increase to try to keep everything in their body going, and then their heart rate's going to drop. So now besides for having a hypoxic baby or a hypoxic child, now you have a bradycardic child. And now you are heading towards CPR. So prepare before you actually set up to intubate or anything. Have all of your supplies ready. Make sure if you're not pre-oxygenated, like if they're still breathing, pre-oxygenate. If they're not breathing, make sure you have a very good seal and you're bagging well. Because the better you bag, the longer they're gonna have for time-wise for you to intubate them. Also, besides for increasing their heart rate and then dropping it, they'll also vagal down sometimes with intubation. So sometimes their laryngeal stimulation just with placing either the McGrath or a Miller blade in, or even just placing a tube down into their throat. Sometimes that's enough to just vagal them down, which is why sometimes we talk about pre-medicating with atropine. Did Steven say anything about pre-medicating?
He said that it isn't something that's commonly used for every pediatric intubation, but if you're having to intubate a bradycardic kid, then you want to give atropine beforehand, and then while part of your preparation is having atropine out and ready. In the event that when you go to intubate, they do brady down, you can quickly lump them with some atropine. So.
Yeah, if you're starting out with already a bradycardic child, I would give them a bump. But just like we say have your backup equipment already ready and near you, have atropine ready to go also. Pediatric patients, we always say they compensate very, very well until they don't. So we always talk about they're climbing up that hill, they reach the cliff, and then they just bottom out and fail. And you will see it. You will see a patient working, doing well, tolerating. You're like, all right, we have time, let's go to the hospital. And then on the way to the hospital, you're gonna be like, oh crap. You're gonna have that oh crap moment because they will compensate, and then they'll just fail on you. That's why even if you think everything is going well, know where your equipment is in your ambulance and know what size of equipment, like have hands heavy pulled up and ready to go and just glance at it and just know like, all right, in the back of my mind, I'm gonna need this size tube, I'm gonna need this size blade, I'm gonna need this size suction catheter. Just have it in the back of your mind because the more you prepare, the less you will freak out in the event that it does happen. The biggest piece of advice I can say for pediatric patients is preparation. The more you think ahead of what could go wrong, the more you're prepared for when it does go wrong, and the less your mind is in the panic mode. When you take away the panic in the situation, everything just kind of goes smoother, right? You're able to give directions to your teammates, everything will go smoothly.
That starts you go on a call and it's a PD call, what should you be doing before you go in? Hands heavy, right? And even though your partner may know what needs to be done, it doesn't hurt to go, hey, if it's a PD arrest and we get there, you're gonna start CPR, I'm gonna do X, Y, Z. So you're just talking it out, help calms both of you guys down. And then, like she said, prepare, like if the thought crosses your head, like there's a chance we may have to bag this patient, what should you have out? A BVM, right? So if you feel like there's a chance you're gonna have to bag a patient to the hospital, if you just have that out, it's less panic on you to try to quickly grab that versus everything's prepared. So.
BVM and your masks, right? Because it's not just one size mask. Adults, it's easy, right? You just throw that mask on. But pediatrics, in your neonatal airway bag or your BVM, it should be 2 different sizes. So depending on how small they are, just either use the preemie mask or the normal size mask. Another thing to say for anatomy that I forgot to put on here, when you bag your small children or even your babies, we always talk about like the EC clamp, right? You put your your thumb and your first finger as a C around the mask, and then you use your 3 fingers to kind of clamp under the jaw. With children, it's a little bit different. You still want to get a really good seal with the mask, and that's why I usually will always say throw an oral airway in, because what happens is if you don't use an oral airway, a lot of people will put those fingers underneath, like a baby is like half the size, like not even half, probably a third the size of my jaw, right? Your fingers are their entire under jaw. So you're gonna take that tongue that's already occluding your airway and just occlude it even more. So when you're bagging, you're gonna be like, I don't have chest rise, I don't have chest rise. Throw in an oral airway, and I usually just put my hands usually on top, and I'll try to just take the bottom of their chin like this and lift forward like this. I don't really use all 3 fingers underneath the jaw, because then you're just occluding the tongue even more, or the airway with the tongue. Does that make sense?
Yeah.
For equipment, we've kind of already touched base on this, but Miller blades for your preemies especially. So when I say premature babies, anything less than 36 weeks is technically considered premature. Probably 36 and above could still use like a size 1 blade. In neonatal resuscitation classes, we usually joke around that there's small, medium, and large for all of our equipment in the NICU world, and it's pretty much a size 1 for all of your late preterm or your term babies is what's going to help you out. For your preterm, like your 22, 23, or like your 21 weekers, those are the babies that you're going to get called to saying, Mom basically sneezed or delivered a baby into the toilet, and you're going to get called being like, all right, crap, it was a unexpected delivery, and baby's very young. Those are the ones that you would probably have the Miller blade out ready to go. For your ET sizes, everybody, if you pull out hand heavy and you put in like any age patient, it's going to give you a tube size. But what I would say is have the tube size larger, the tube size hand heavy says, and then the tube size larger. So 1 smaller, 1 equal, and 1 larger. And the reason for that is hand heavy kind of throws everyone into a generic pot and says all 4-year-olds are going to be the same, all 6-year-olds are going to be the same, and it helps us out, right? It takes out the guesswork. But at the same time, you're going to get to the airway, and then you're going to be like, I think I need a smaller tube. It's not going to fit, right? There's going to be that one outlier that you're going to be like, I need a smaller tube, and if you have it already ready and next to you, you don't have to freak out again. For your bougies, I have it up here, but your pediatric bougie will only fit on a 4.0 to 6.0. I wrote that right?
Mm-hmm. Yeah.
I think the adult bougie, we tried it and it fits in a 5.5, but it's super tight on a 5.5. Like, you would have to hold your 5.5 tube like very well, and it's going to be a snug, like, pull it. Like, if you don't have a good hand on your tube, you're going to extubate as you're pulling that bougie out. But it will fit in a 5.5. I would just use a pediatric bougie if it was up to me. Anything less than a 4.0 on a pediatric tube will need a stylet. Everybody kind of has different ways of how they shape their stylet. The biggest thing I can say is don't put your stylet past the end of your tube, obviously, right? You don't want to put it past to the point where you're going to poke through their carina. But you also want to kind of hockey stick it. So if you put your stylet in your tube kind of like this, then when you put your blade in, you can usually just turn your tube however which way you need and kind of hockey stick it into the airway.
I think the bougie stuff, as far as stylet, what bougie fits on what tube is extremely important, because I think Stevens pushes bougies a lot, and then we get in the heat of the moment and we're intubating a kid, and we go to put a bougie down a little infant, and then we realize that we can't pass the tube over it, and it creates panic. So knowing this, we're putting it in your brain so that way when you're in those moments, we're not going in and doing an attempt that we can't actually secure an airway in and having to create that panic of not being able to get the tube in. So.
And off of that also, Another reason I always say to have a tube size smaller is the more intubation attempts and the more attempts you are messing with an airway, what happens? You're causing trauma, you're causing edema, you're making that airway swell up. So the more attempts it takes to intubate, like I won't expect every single person to intubate on the first try, right? Pediatric patients, we're freaking out, parents are freaking out, everybody's in a kind of panic mode, but if you just kind of talk to yourself, slow down, hopefully you'll be able to talk yourself and get it on the first try. But if you don't, like Tate said, if you put a bougie in and then you realize, oh, my tube's not gonna fit over, and now you have to pull that bougie out and then insert something else, that's trauma, and you're gonna make the airway swell up a little bit more. So what you thought could have fit before might not be able to fit this time. So have your backup equipment ready to go. Suction catheters are super important also, because kids are very drooly, snotty, and they just generally are gross. I love them, but kids are gross. They will have a lot of stuff in the back of their throat, so it might obstruct your view. And yes, snot and just normal drool is clear, but it's just enough that you're gonna be like, I can't see anything, I can't identify any anatomy. Well, if you take a soft tip catheter, just suction out, all of a sudden your airway is beautiful, it pops right up. How many of you guys have gone on croup calls? Have you guys used our racemic epi?
Yes.
Works well. Okay, on croup is usually 3 months to 3 years old. Just like how I said RSV and flu don't really have a season anymore, croup also, we've gotten outliers where kids will come in the middle of summer and they'll have that barking seal-like cough, and you'll be like, oh, you sound like you have croup. But it's usually 3 months to 3 years old. They're usually your younger kids. The reason why it affects them more is just like how we said, your airway on a pediatric patient, the larynx, everything, it's a little bit smaller, so it doesn't tolerate edema as well. So as the airway is kind of closing in, their barking seal-like cough is them trying to get that air past that swelling throat. So that's why it sounds like a seal-like cough, because it's basically stridor. It's them like having a stridorous cough. You'll also hear them having just at rest, like upper airway stridor when they're breathing. Treatment for these guys, put them on oxygen, give them a dose of racemic epi, nebulized. If you can get an IV on them, go ahead and try. If you think it's going to upset them more and cause them to freak out or panic more trying to get an IV, just give them oxygen or racemic epi and transport them. But if you can get an IV, steroids are going to help them later down the road. Steroids are not something that happen like immediately. You're not going to see immediate effect, right? But in a few hours, they'll take effect and that airway will start to swell, or the swelling will decrease. But to place an IV for us in the field on like one of these patients, if it's going to cause them to panic and freak out more, it's going to make them hyperventilate, and then breathing will be worse. So if you think they're tolerating it fine, have your stuff ready to go if you need it, but otherwise just transport them. That's what I would say. Has anyone gotten a call for possible epiglottitis or true? Has anybody seen epiglottitis? No.
Seen in the hospital, but never pre-hospital setting.
How old were they in the hospital?
Still in a regular carrier? I don't remember, but pretty young.
So what we're starting to say about epiglottitis is it's, I think it's caused by the Hib, what am I trying to say? Virus? I think it's a virus that causes it. But which I put on I know my own slides, I swear. So it's caused by the Hib infection, bacterial infection. For most of us, we all get vaccinated for it, and we don't have to worry about it. But a lot of parents are saying, hey, I don't want to vaccinate for some reasons. So because vaccines are going down, we're actually seeing an increase in epiglottitis. The problem with it is, remember how I said that floppy get in the way epiglottis for pediatric patients, that's already our problem? With this, it becomes super critical. If your epiglottis swells to the point of blocking your airway, you are SOL, and you are pretty much in a panic mode for even the most experienced people. The reason for that is the only option left is to crike. On pediatric patients, can you actually surgically crike them? Yes or no?
If you're lucky, maybe.
So under 12 years old, theoretically, you're not supposed to surgically crike. You're supposed to needle crike under 12 years old, which I don't even think we have.
We don't have protocols for it.
Yeah, so we don't have a protocol to needle crike under 12 years old. So if that is truly what's happening, that is a shit your pants moment.
Zach had he had a case where a kid got injected from a car and had really bad facial trauma, and the kid was like somewhere between the age of 4 to 6, and they were able to actually palpate landmark and did a surgical crike on the kid.
Oh, yeah.
So it's not to say that it's
Impossible or an absolute no.
but it's probably not.
The reason they say no to surgical crikes on anybody that young is just because everything's a lot more, like for an adult, it's very easy to identify landmarks. Everything's a little bit more firm. It's not moving around. It's not wobbly or anything. For a kiddo, it's a lot shorter area space and span to go. Yeah. So that's why they usually say to needle crike, but if you can find the landmarks, then yes. But
That's a Dr. Stevens call.
that's a
panic.
That's a Dr. Stevens call while you're making other decisions. This is like, so when I worked on pediatric transport, this was the call that we always prepared for, like making 3 decisions ahead in your, like while you're doing other things. The reason I say that is because if your pediatric patient that you see is in a tripod position when you get to them and they're just drooling, like can't close their mouth, the only way they're able to breathe is in the tripod position, and everything that is coming out of their mouth is just like falling out, transport them in the easiest way. If that means putting mom on the stretcher and putting kiddo on their lap and keeping them calm, transport them that way. Don't even try for an IV, just have your IO stuff ready to go, because if stuff goes sideways, it's gonna go bad sideways. But the more you antagonize or upset them, the worse the airway is going to be. This is that moment where you have all emergency equipment in your head ready to go, and like you said, call Stevens and just say, hey, we're going to a pediatric facility. Where's a pediatric facility? Yeah. TCH West, that's a far drive. Memorial Herman Katie, that's far drive. If it was me, I would honestly just go down West Park, because West Park's probably going to be quicker, lights and sirens to, I don't know. Nowadays, getting to Memorial Herman Katie is a joke. But if it was me, I would just probably go downtown. You could also call Lifeline if you don't think it's going to be that long. If it's a long wait, I would just start transporting.
You're going to be very happy. Be very happy.
Lifeline would?
Oh, yeah. I know I'd be.
Huh?
I'd be like, no, guys, don't give me this.
But Lifeline has needle crike in their
They do
protocol.
have needle crack, that is true.
They can do it. I can't, theoretically. With croup, it's a little slower onset. They're not as drooly, and they're not as, like, they look sick, but they could still be running around and having that bark-like seal cough. Epiglottitis, these kids look sick. You just like will walk in and you're like, oh, something's not right. It's usually a sudden onset and it rapidly progresses. Like mom will call and be like, 2 hours ago they were breathing fine, and now all of a sudden they're not, and they're sitting up, they can't breathe, and they're drooling everywhere. So for epiglottitis, it moves fast, which is why I said think three steps ahead and be making phone calls and decisions while you're getting on the road and going. So this is basically what's happening. On a healthy baby, you can pretty much see the openings already pretty small and narrow. Inflamed, all of this will just basically inflame all the way till you have nothing. Bad, 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 bad. The other thing with epiglottitis is, Remember how I said the more attempts you take to intubate and the more attempts you take to stick anything in an airway, it's trauma. You're going to cause edema, inflammation. It's already inflamed, right? So if you think you have an airway, you will have like one attempt, and that's it. I wouldn't even try it, honestly, because you would stick it in and just cause it worse. It would just be bad.
I think Stevens was like
Just transport, honestly.
transport, yeah. Try not to intubate.
Did he say anything about epi or anything? Like IM epi?
No, he said that it's probably not gonna, you could
Do
try
anything.
it, it's probably not gonna do very much.
And again, it would just
Make
cause
it
them
mad.
to be mad and start breathing faster and make everything worse. So like we said, keep them calm. Don't attempt an IV. If the kid is like 2-3 years old and they don't want to, they're like the kid that like latches on to mom or latches on to dad and they don't want to let go, put mom or dad on the stretcher, strap them in, and then strap them down, and then transport like that. Keep the kid as calm as possible. If that means sitting all the way up in a tripod position the whole way there, keep them that way. This is the one time, like, I would say, like, strap them down and make sure they're secure, but get them to the hospital. You could have oxygen, like, in a mask ready for them, like, just to hold near their face. Most of these kids, I think I've seen it once in my career, and this kid was just more of a, like, don't come near me, just leave me alone kind of thing. But if you want, you could hand them the oxygen mask for them to hold, but I would not give it to the mom or the dad, because the first thing the mom or dad's gonna be like is like shoving it on their kid, like, oh, they need it, and then they're gonna make the kid freak out more. Remember how I started and I said, pediatric patients, you don't have one patient, you have multiple patients, because you need to think of the family member also. This is one of those moments where you need to work on calming the parent down also, because some parents are the most oblivious people in the world, and you're like, yes, you don't realize this is a really bad moment. And then there's other parents who are freaking out and causing it worse for the kid, right? The more the parent is amped up, then the kid looks at them and is like, oh, I need to be amped up. So then the kid is gonna get freaked out. So you don't have one patient, you have multiple patients. Calm down the family member and your job will be so much easier. And just talk to them. Don't panic. Just talk to them like you would anybody else. They're people. Even the kids are people.
On the inside.
Yeah.
Cry on
Just
the
like
inside.
shit your pants after the call and then you're fine. Everything will be good. Did any of this help so far? Okay, this is a quick video on fetal circulation. And the reason we talk about this before I go into neonatal resuscitation, the quick down and dirty version of the class, is because most of us don't really know what the fetal circulation is once baby delivers. We know that they're on their own circulation, but it takes a little bit of time for them to get from what they were on in mom to where they're at outside on their own in their body, right? So that's why we give them a few minutes. This video will explain why the circulation, we give them a few more minutes after delivery to kind of get in their groove. Alrighty. How many people remember going over fetal circulation ever? Did they go over it?
For like this long.
For like a hot second, right? There's a lot of things on that video that, like, me having 7+ years in pediatrics makes sense to me. But one of the biggest things is, did you hear how he said oxygen causes the PDA to close, and also oxygen carrying blood causes the umbilical arteries to kind of clamp down and shut off? Remember how we talk about oxygen toxicity and, like, adults, too much of it sometimes is a bad thing? Neonatal patients, too much oxygen is very bad. Too much oxygen will close off stuff, and if they need it, that's bad. So that's why when we start to resuscitate kids, start with room air. If they can tolerate room air, then go from there. Then give them, like, if that room air would mean, like, take the bag and just bag them with whatever you have. You don't need to hook it up to oxygen. Sometimes kids need that PDA to be open. The other thing, when he mentioned fetal circulation, is bypassing the lungs. Kids don't need to breathe when they're in utero, right? They're swimming in a swimming pool. That being said, when they come out and that you go to your first delivery and you're like, that kid looks like he's struggling to breathe. Well, he's kind of opening his lungs for the first time. Kind of give him a break. He might need help, but they're opening those airways and those lungs for the very first time. Beforehand, they were collapsed and full of fluid. They didn't need them. On here, this is just a quick view. Has anybody heard of delayed cord clamping being a thing? How many of you guys? Raise your hands. Sweet. When we say delayed cord clamping, how long do you think delayed cord clamping is?
I feel like it's something like 15 minutes, right?
Ouch.
Like a long thing?
Nah. Usually we say like 30 seconds, up to a minute maybe. 15 minutes though is not unusual because you're still gonna, like, we will get called from dispatch to go to delivery, right? And mom might have delivered 5-10 minutes ago. People don't know to clamp the cord necessarily on their own, right? So I'm not saying it's a bad thing, but you don't necessarily want to wait that long. 30 seconds to a minute is usually what we say. The reason they're talking about delayed cord clamping, the reason I'm talking about this is for us, like, if we get to someone and they're like actively pushing, you're gonna deliver a baby, you're gonna be the hero for the day, the kid is gonna be named after you from now on. It's yours, basically. You can decide to delay clamping for about 30 seconds after they're born, if baby's doing okay. Like if baby's breathing, pinkening up, everything looks good, you can put that baby on mom's chest, let her swaddle, keep that baby warm, and then wait 30 seconds to a minute. That makes the blood count in the baby a little bit better, like their hemoglobin, hematocrit will look better. It just gives them a little bit more oxygen carrying blood to get to them. And what we've been seeing is they do a little bit better down the road. If they're not doing well, like if they are not breathing, they're limp, they're apneic, they need help, then just go ahead and clamp the cord and go from there. Does that make sense? But yeah, eventually you will get to the few people who will call very long after they've delivered. So this is the neonatal resuscitation program. This is normally a 4-hour class for everybody else, but I'm going to kind of brief it down to the most important parts. Biggest things, when the baby is first born and comes out, you want to ask yourself 3 questions. Do they appear term? Like, are they well-developed? They look like a baby to you. They don't look super small, like to the point of like premature. They should be in an isolette still or inside mom still. Do they have good tone? Like most babies when they're born, if you think about them in utero, they are pretty much clamped up in a fetal position, right? If they are born and they are still kind of clamped to themselves like this, that's good tone. But if you have a baby that's just like this, that is not a good thing. If they're breathing, it means they're screaming and crying. If they're a calm baby, they might be abdominal breathing, like I said. But if they're crying, they're breathing. They're doing great. They're doing their job. If those 3 questions are answered and they're all good, put the baby on mom's chest. Mom is going to be the best incubator and the best heat warmer for the baby. So just have mom like pull down her shirt, whatever she's wearing, put baby on her chest right here, cover her up with a blanket, you're good to go. Transport. Bless you. Every baby, once they're born, will get what we call the 5 initial steps of resuscitation. That's this line right here. Every baby, you're going to warm them, you're going to dry them, and you're going to stimulate them. You do all 3 of those things at the same time, right? You take a blanket, you're drying off all the goop and the grossness, you're drying them off, you're warming them up, and you're stimulating them at the same time. When we say stimulate a baby, what we mean is rub their back, rub the bottom of their feet. You can flick the sole of their foot to kind of get them to breathe a little bit more, but it's mostly rub their back and flick the sole of their foot or stimulate the bottom of their foot. The other 2 parts of the 5 initial steps is position their airway. Remember what I said for infants? They have very large heads. Put a shoulder roll underneath their shoulders. Get their head lifted in an optimal position and suction them if they need. Remember, babies are obligate nose breathers. So you want to suction their mouth first and then their nose. The reason I say mouth first is because if you suction their nose, they're used to using their nose. So if you suction one there, they're gonna like immediately take breath in and suck whatever you're trying to get out in. So suction out whatever is in their mouth first and then suction their nose. If after, so say the first 3 questions, term gestation, good tone, breathing and crying, one of those is a no. Say they don't have good tone, and they're not really breathing, say 40 to 60 times a minute. They're not crying, but they don't really look like they're breathing that great either. They'll probably look pale, and just not generally like a good newborn. You do the first 5 steps, you've positioned them, you've stimulated them, you've dried them off, and you suction them out. Say they're still not doing well. Then you want to assess, are they breathing? If they are breathing effectively? Or also put a pulse ox on them. Once you put a pulse ox on, is their heart rate less than 100? When you put a pulse ox on a baby, where do you want to put a pulse ox on? Right side of what? Right foot? What other guesses we got?
Right wrist.
Right wrist. Why do we say right wrist? Does anybody know? So remember how I went over fetal circulation right before this one? And it said we bypass the lungs and the PDA is open to kind of bypass the initial part of the aorta where it goes then to the rest of the body to oxygenate and give whatever it needs to the body. If you put a pulse ox on any other limb, left wrist, feet, wherever, you're going to be post-ductal, which means you're going to have a false high reading because that's where the oxygenated blood is going. If you put your pulse ox on your right wrist of your baby, you're going to have an accurate reading of what truly your oxygenation is doing. So right wrist for all of your pulse oxes. Your pulse ox should give you a heart rate and your pulse ox, right? Less than 100, that's not optimal for a baby. A baby's heart rate is usually anywhere from 100 to 200. That's a very generic, wide range, but in my head, I just remember easy numbers, so I say 100 to 200. Less than 100, they need help, and help for them is breathing. Most babies do not go into cardiac arrest for a cardiac reason. Most babies go into cardiac arrest because they were initially in respiratory arrest. So we help them out respiratory first, and then you prevent the cardiac collapse later on. So heart rate less than 100 means they need help with breathing, which means we bag them. Even if they are kind of breathing on their own, they might be gasping, but what do we always say in EMT school? Is gasping effective breathing? No, right? You're going to bag them. Same thing for an infant. It's a lot easier to bag a baby than it is an adult. They're not going to really fight you. These babies are going to tire out very quickly if you don't help them out. Those are the babies that you're going to put the mask on, position them first, put the shoulder roll underneath them, bag them, wait 2 seconds, bag, 2 seconds, bag. If once you start bagging them, you'll notice they'll pink up, they'll start to move around a little bit more. Once their heart rate goes above 100, you can try taking off the bag, like stop bagging them and giving them breaths and just see how they do without that. They might just need a little bit of air being blown next to them. But initially when you're bagging them, you can just start bagging with room air. You don't necessarily need the oxygen tanks that we're hooked up to. The reason I say that is because our oxygen tanks, it's like all or nothing. It's all oxygen, right? It's 100% oxygen. In neonatal world, 100% oxygen, we only use when we're doing like compressions on a baby. Otherwise, we use something called a blender, and we blend air and oxygen together, and we titrate. We can go anywhere from like 21 to 30 to 40%. You can gauge how much oxygen you're giving the baby. But 100% oxygen in a neonatal world is reserved for when you are doing compressions. So if they can tolerate bag masking with just room air, try it. They might need oxygen. I'm not saying it's a black or white yes or no. Everything's gray in our world, right? You might need oxygen, but try room air first. So say you're bagging, your baby's limp, they're no longer breathing, they're not doing too hot, and their heart rate's dropping. If after a full 30 seconds to a full minute your heart rate is still less than 100, you want to ensure that you are adequately ventilating your baby. The biggest thing with neonatal resuscitation program is adequate ventilation. They say it like 500 times in the book. What they mean by that is you need to make sure your seal is good on your mask, you need to make sure you have chest rise, you need to make sure you've suctioned and opened up the airway, that you're positioned appropriately, and then if all of that doesn't work, then you need to ensure that you have a secure airway, which means, or an advanced airway, which means intubate. After that, say you've gone down all of the steps and you're now at a heart rate of less than 60, but you've intubated and you know your tube is in the right spot, you have chest rise, you have all of the right stuff going on, then you're going to start compressions once your heart rate goes below 60. And at that point, what did I say about your oxygen? Once you start compressions, then you're going to give them 100%, which just means our tanks or what's in the ambulance. Compressions, I would go off of hand tubby or what you guys know for PALS. Neonatal resuscitation, they do CPR very differently. Remember how I said heart rate is 100 to 200 for an infant? Neonatal resuscitation, we usually do 1, 2, 3 compressions and then we bag. 1, 2, 3, and then bag. If you don't feel comfortable remembering that, I would just go back to what you know for PALS or how to resuscitate a pediatric patient. The one thing that is easy about neonatal patients is that there's 2 drugs, epi and normal saline. Epi, obviously, to get their heart rate up and above 60, because once your heart rate's above 60, you don't have to do compressions anymore. You just need a bag and breathe for them, or help them breathe. Bless you. Normal saline, we say, is the other drug. That's your volume expander, right? So does anybody know what the dose for normal saline is for your pediatric patients or your infants?
10 mils.
Awesome. 10 mils per kilo. How many people know how much a baby weighs when a baby comes out? Like, none of us, right? And especially not in kilos. I'm like, you look like you're like 4 pounds. I don't know what that is. You could just guess and just try with 10 mLs first. This is not a rapid, so think about it. So 1 kilo kid, 10 mLs is a bolus for them. 10 mLs is a flush in our truck. You do not want to, so for most of us adult patients, we just rapidly push that flush in and it's said and done, right? On an infant, you do not want to slam that flush in a baby, because if you slam a flush in, all that fluid is going to be an immediate volume expander, bad for their brain, bad for a lot of things. You want that 10 ml flush to go over, say 10 minutes. You slowly push it, push 2 mLs, go do something else. Push 2 mLs, go do something else. Think about it first. Volume expanders come into being kind of when you're thinking, hey, my patient looks really pale. They're not pinking up even with oxygen, even after doing compressions, even after epi. Their heart rate's not improving. We know we have adequate ventilation. We have a tube in the right place. We have chest rise, all the right things, and they're just not pinking up. And then think about mom's case. Say mom was like, hey, I was bleeding a lot before I delivered her. Or say mom was in a car accident and she's bleeding, say, in her belly somewhere. If mom is bleeding, baby is bleeding. So if mom looks pretty pale, baby is probably needing blood. We have blood. I would not give our blood to a baby. I would do volume expanders and then get them to hospital where they can get the right type of blood for them. One thing we're going to go over a little bit. Does anybody have any questions about this part? It's when you pull this up, first of all, if you have a baby that's crashing on you, this is going to be the one thing that you're like, please hold. I need to pull up my diagram of how to resuscitate my baby first. Yeah, please hold off. Like, breathe for a little bit longer. I need to look this up. Just review this every once in a while. For me, I've been teaching this for 11 years. This is like backhand knowledge to me. But for you, remember, pediatric patients, those are the moments where we're like, oh God, it's a panic moment. If you are going to a call where you think you're gonna deliver a baby, pull this up, just go through it and look through it. The biggest things are you want to ensure that they're breathing correctly or adequately, which means good chest rise, their heart rate's above 100, they're not working hard, they're pink, and they have good tone. If their heart rate's below 100, you want to help them breathe. Either give them oxygen if they need it, or give them breaths manually with a bag. And then if their heart rate drops below 60, that's when you start compressions. Always position your baby optimally, meaning a shoulder roll. So those are the biggest things. Positioning, less than 100 heart rate, you need to help them breathe. Less than 60, you need to help them breathe and live. Remember how we said all of the delayed cord clamping and the fetal circulation? That is not solved immediately, right? So once you clamp the cord, it's gonna take a few minutes for the baby to kind of get their act together. In neonatal resuscitation, we give them 10 minutes to get their act together. So what that means is, I don't want you giving 100% oxygen within the first minute, because in their first minute of life, their oxygen saturations should be 60 to 65%. They have 10 minutes to get their act together. 10 minutes, and then they have to live on their own. Then they're, yeah, then land. But that's why I don't want you, so a lot of people will put a pulse ox on the baby on your right wrist, right? And they're gonna see 60 to 65, and they're gonna be like, oh my God, you need a lot of help right now. No, you have 10 minutes to get up to 94%. And even at 10 minutes of life, you could be setting 85%, and that's still acceptable. 10 minutes. That's all you get, kid. Also 10 minutes because, like I said, their lungs are initially collapsed down. So they're taking breaths for the first time to open up that airway. The first breath is not going to usually do it. They need a couple breaths to open up, get everything, oxygen, whatnot, moving through them. So for neonatal resuscitation, what did I say the first 5 steps are? Warm, dry, stimulate, position their airway, and suction. Warm and dry them, stimulate them just by drying them off with a blanket. Position their airway, just put their head up a little bit. They call it into the sniffing the morning air position. Just like that. And then clear their airway. Keep all of our babies warm. Even though it is now 90 degrees outside, that is cold for a baby. You want to put them on mom's chest, skin to skin if you can, and then cover them with another blanket. That will keep them warm. Or swaddle them in whatever blankets or sheets that you have to keep them warm. I feel like I've drilled in positioning the airway quite enough for you guys. Remember how I said respiratory arrest will lead to cardiac arrest. After your 5 initial steps, determine your heart rate, less than 100. Give them breaths. Breathe 2, 3, breathe 2, 3, breathe 2, 3. I just said that really fast. It's more like compress the bag, 2, 3, breathe, 2, 3, breathe, 2, 3. It's what we always teach in the class is it's a waltz. So for your baby, if you're breathing for them, remember your waltz. Breathe, 2, 3, breathe, 2, 3. Does anybody dance? I don't dance, so I don't know what a waltz is, but I feel like I know the cadence. Remember, typical respiratory rate for a kid is 40 to 60. So what we think is, the other thing is it's easy to get distracted, right? So whoever I say is in charge of airway on a baby, that is their sole purpose, is airway. Remember, everything respiratory, if you don't solve respiratory, they're gonna lead to cardiac collapse. So whoever's in charge of the airway, that is your sole job. If that is my EMT bagging that baby, I want you to make sure you have a very good seal with a bag and mask. I want you to make sure you're not compressing the tongue and collapsing or blocking your airway. And I want to make sure that you have a shoulder roll under them and that you actually have good chest rise. And then talk yourself through the waltz. Because if you talk out loud the waltz, it sounds ridiculous to say, but if you verbally say very loudly, breathe 2, 3, breathe 2, 3, no one is going to ask you questions. No one is going to be like, hey, can you grab that monitor for me? Hey, can you grab that piece of equipment for you? They're going to be like, oh, you're busy. All right, never mind. They're going to leave you alone. But if you just say it to yourself, people are going to distract you, and you're going to be like, oh, yeah. And then you're going to walk away, and 20 seconds later, that baby has now missed 10, 12 breaths. Bad, right? If your heart rate responds and increases, continue bagging until the baby comes responsive. What I mean by that is, like, if they are screaming and moving their legs and their heart is above 100 and their pulse ox is doing what it should be doing, remember, how many minutes do we give them to get to 94? 10 minutes. If all of that is improving, you can slowly take the bag away, stop bagging, and just give them supplemental oxygen or air. See if that helps them out. And they might just need a few breaths to get their act together. Some babies need very little. Some babies need all the help. And then, like I said, if your baby is still limp and apneic, but your heart rate has increased, limp and apneic still is not a good thing, right? Because the minute you stop bagging, nothing's going to work, right? If you are effectively bagging, though, and your heart rate is responding, and you think you can make it to the hospital the way you are positioned, and with someone driving not crazy to the hospital, the reason I say that is because a baby is a very small patient, and you have a good mask seal the way you are right here. The minute you start driving, going down Houston roads, everything's bumpy, and then you're moving around like this. And now you, A, can't see your chest rise as well, and B, you're not going to be focused as much on the baby. You're going to be focused trying to stay in one spot, right? So if you think you can make it with just bag mask ventilating to the hospital, just drive slow and steady, and just make sure you have a good seal and good positioning. If you don't think you can make it to the hospital, or if baby's not responding well, that's when you need to intubate. You need to intubate, and then you need to secure the tube, how I taught everybody to secure a tube on a baby patient. Tape. So the tape I'm talking about is that white tape. It's a waterproof tape. So remember how I said kids are very drooly, gross kids? Waterproof tape will stick a lot better. So it's not going to slide off, and then with the tape sliding off, there goes your tube. The reason we talk about like securing a tube in neonatal resuscitation, we use cuffed tubes here. If you can get a cuffed tube of whatever size Hand Heavy says into a baby, use a cuffed tube. In neonatal resuscitation, if you guys ever take this class on your own, they use uncuffed tubes. An uncuffed tube is a very different story, because if you have an uncuffed tube, turning your head is going to extubate your baby. Remember how I said shorter airways? If you're in, once you're in, that's another good point to bring up. So if you intubate a baby, just turning the baby's head can pull that tube into the wrong position. Keep them midline, like put the shoulder roll still underneath them, but keep them midline. You don't want them to turn like this, especially with the vent tubing and all the heavy equipment. All the equipment is going to be super heavy and want to turn their head. It's going to extubate them. That airway is very, very short. You don't have a lot of wiggle room on them.
I was bringing a point. One thing Stevens brought up is if you're having there's a delivery that's about to happen or has happened, he would prefer you to call a second ambulance right away in case if something goes wrong with baby. All your resources are there, and then you may not be able to effectively take care of mom. So just call a second ambulance.
Also, especially if mom looks like she bled a lot and mom isn't doing well, it's just a good thing to have a second ambulance anyways, because if mom, remember how I said if mom's bleeding and not doing well, means baby might not. Like, baby might be doing well for now, but might need help in a few minutes. Does anybody have any questions so far? So ventilation corrective steps are what we call Mr. SOPA. If you don't see chest rise when you're bagging, you want to go through your ventilation corrective steps. The biggest thing on babies is ventilation, and then you won't go into cardiac collapse. I don't know how many times I can say that, but I think it's important. Mr. SOPA stands for the different things we're going to do to accomplish effective ventilation and effective chest rise. So the newest edition of NRP has changed it from Mr. SOPA to Mr. SOPA. It's like changing it into a little bit different. So I kind of put them in groups together. So together you're going to do mask readjustment and reposition the airway. What do you do when you take a bag off or a bag mask off of an adult patient if you don't think you're getting good chest rise or a good seal? You're going to like position the airway better and then put the mask back on. You did two things at once without even knowing it. So now mask readjustment and repositioning your airway, you're going to do those together. You're going to give them a good 3 to 5 breaths. See if you get chest rise with that. If you don't get chest rise after readjusting the mask and repositioning their airway, then you're going to move on to S&O. What did I say? Babies are obligate nose breathers. So you suction their airway first, or their mouth first. Well, what do you have to do to suction the mouth? You have to open the mouth. Congratulations, you did 2 steps at once. So suction your mouth, suction your nose, keep in mind the positioning of the baby, reapply the mask, give them 3 to 5 breaths, see if you have chest rise. Usually those 4 steps will give you chest rise and you're good. What's your question?
Why do we do the mouth first?
So babies are obligate nose breathers, which means if you suction their nose and all of a sudden that kicks them into, oh, I need to breathe on my own, you can't suction both nares at the same time, right? So you'll suction one, and then they're gonna immediately inhale whatever you're trying to suction out. So suction the back of their throat first, try to get whatever you're trying to suction initially, because most of it will kind of pool in the back of their throat anyways, and then suction their nose. Does that make sense? If you ever get lost, they always teach it like alphabet, follow your alphabet, M comes before N, mouth before nose. Lots of tricks. If the first 4 steps, mask adjustment, repositioning your airway, suctioning, and opening the mouth don't really do anything, then you can increase your pressure. What we mean by increasing your pressure is your PIP. What does PIP stand for again? Peak inspiratory pressure, which is your what breath? Your inhale breath, right? Your what breath you're squeezing the bag and pushing that air into the baby with. On a baby, on the BVM, you'll see a little dial with your manometer for pressure. You do like a pressure for a breath for a baby is 20 for inspiratory breath. So on your bag, you're gonna see green, yellow, red. Green stops at 20. If you go above the green mark, you're too much pressure. You're gonna blow a pneumo, most likely. Like if you're in red, you're definitely gonna blow a pneumo. But 20 stops at that green mark. When they say pressure increase, so that's the other hard thing about bagging a baby manually, right? Every time you squeeze that bag, you need to hit 20. Are we hitting the same pressure every time we squeeze that bag? No. Going down the road, are you hitting that same pressure every single breath? Definitely not. You need to practice just bagging a neonatal bag on your own because it's harder than it looks. Like sometimes you just use your thumb. Sometimes you use your thumb and your finger. But getting to 20 every single breath is nearly impossible. And when they talk about increasing the pressure, they mean by going from 20 to 22. It's like minimal. And we're probably hitting that without even knowing it every other breath because you're not going to hit 20 every single time unless you're AI or a pro.
I think these BVMs have a pop-off valve.
Pop-off valve happens at 40 or 30. Depends what type of bag. I don't know what our pop-off valve
I
is.
think, I have to look at it, but I wanna say it's 20 to 25 is like
The pop-off,
pop-off valve. Like it stops there.
I'll look it up after this class, because usually a pop-off valve, it'll either pop off at 30 or it'll pop off at 40.
Okay.
And what it means by pop-off valve is that means if you squeeze the bag as hard as you can, it has a excess valve that lets the rest of the pressure breathe off after it hits 30 millimeters of mercury. Usually it's 30 on a bag. 30 is extremely high for a baby. Remember how I said we start at 20 and we might increase to 22? 30 is like, that's a lot. A lot of air. And A, your last, Mr. Sopa, alternative airway or advanced airway, whichever A you would like to choose. That being said, intubate. If none of these are working, you want to get a secure airway through the cords and get air directly into the lungs. How does everybody feel about Mr. So, PA? Mr. and So are pretty easy. Those are, you're gonna do those without even thinking about it or without even knowing it. You're gonna accomplish those tests easily. It's the pressure increase one that you wanna watch. An alternative airway, you just wanna make sure, remember what I said, have your backup equipment ready to go next to you. Backup equipment meaning have your Miller blades ready and laid out, because if McGrath doesn't work and you need your Miller blade, have that ready to go. Also have a tube size that Hand Tubby says, and then one less and one more than what Hand Tubby says, just in case. Especially it being, what's it say?
25.
Really?
Yeah, so this is our BBM, and normally this is covered. So if you unclip the pop-off valve and you squeeze it, it won't let you get above 25.
Well, hot damn.
So that's
25 is good.
probably something that if you're bagging a neonate, like she said, I'd make sure my pop-off valve is.
But the pop-off valve is usually included.
Yeah.
So then, on an infant, a neonatal, I would just take it off. Like,
Yeah.
take off the pop-off valve so that you can't give too much air and too much breath. So remember what I said, what pressure are we aiming to hit every breath? 20. 20. Try to hit 20 on a breath.
So it's a safety mechanism, won't let you give above 25.
But 20 is your goal. It's impossible, right? In the 5 years of being a NICU nurse, I learned to bag with my thumb. I would compress the bag with my thumb. Other NICU nurses compress it with their thumb and finger. It's not a full squeeze. All right, to review, like I said, your main goals with the neonatal resuscitation are if your heart rate's below 100, you have to breathe and help your baby out. Effective ventilation, remember? That's what's going to prevent cardiac collapse. If your heart rate goes below 60, just like in PALS, start CPR. But start CPR after you know you have effectively ventilated your patient. You've gone through Mr. Sopa, you have chest rise, you have an advanced airway in place, you still have chest rise, your baby's just not responding heart rate wise. Any questions? Once you've started CPR on your baby, obtain IV or IO access. How many people feel super confident starting an IV on a baby? Every single person. I'll take it, Macy.
Your hopes.
Heck yeah. What size needle do we use on babies?
24.
What color is the 24 gauge?
Yellow.
Yellow. That's probably going to be your only gauge you're going to use. A 20 gauge would be so if you think about it, if you are starting CPR on a baby, they're not doing so hot, and their veins are probably not going to be really plumped up and ready to go for you. They're going to be pretty collapsed down and hard to find in the first place. So a 24 gauge is probably going to be the best bet. That being said, how we just said, your baby is clamped down and collapsed down already. You might not get IV access. You can attempt, but you might not get it. It's not a bad thing if you don't, but you need to go to an IO. What is our first choice for IO in patients according to community protocol now?
For the pediatric?
Pediatric.
I'll start this one.
Distal femur.
You almost
Yeah, almost.
Say what?
I said you almost
I almost
said
said tibia, but I meant to say it.
Well, I will add to, I don't know if Stevens liked this slide or not. He probably didn't.
What particular do you
So
think that
on infants or pediatric patients, you really have less sites to kind of go off of. We usually say distal femur, and then if that doesn't work on an adult, then you can go humeral IO on an adult, and if that doesn't work, then you have your distal femur on an adult still. For children, you don't have that option of humeral IO. A shoulder IO on a pediatric patient is not going to be effective. They don't have the anatomy and the growth to allow fluid to even go into the humeral head of their bone. It's not even a space that has the marrow. Like, I don't even think it's really developed enough for that.
No, I think they teach 10 is about 10 and above is when.
Yeah, so for a baby, that's not even an option. Don't even look at it. That being said, if you drill your femur and you miss, or you go through and through, and now your needle is sticking out the backside of your femur, you cannot, theoretically, according to EZIO, drill lower, below that. So now, if you've drilled your femur, you no longer have your proximal tibia to drill. And now you only have one more site on an infant, your other femur. Or you could drill proximal tibia.
No, I teach that. I tell people like
I'm like, that's like against the
that way
protocol.
you have 2 more options.
Yeah.
Versus,
If it was me on an infant like this, I would start with proximal tibia. When you guys, does everybody know how to find the site for proximal tibia? Somebody tell me. How do you find it? Anybody? Everybody jump up all at once. Scream. That was you raising again?
Down below the patella, and
So-
then you go medial.
Correct. So 2 finger widths might be a little bit much on an infant, only because we have adult-sized hands, right? Theoretically, they always say use your patient's hands and fingers. So you want to just go, so if you bend your knee, everybody bend your knee and feel. You're going to feel a little bump at the base of your knee. And then if you go medial, you're going to find the flat point of the tibia. Does everybody feel that flat point of the tibia? It's a really easy spot to hit. That flat point of the tibia is what it will feel like on an infant also. And that's where you can drill. Keep in mind, we don't have the pink IO drill or the pink IO needles anymore, right? We have blue. It is going to be super easy on an infant to drill through and through. Your femur, your tibia, any bone. So A, don't hold behind your drill because you're going to drill into your hand and be one with your patient. Not the greatest idea. And you're going to walk in and also need to be a patient. But what I usually do is take like a towel, roll it beneath the knee, bend their knee like this, and then you have the optimal positioning to hold right here and drill. But if you put the towel beneath their knee, you don't have to hold beneath the knee or anywhere near where you're drilling. You can do the same thing for a distal femur. Distal femur, just go above your knee. You can go either dead center or you can go slightly medial to avoid the tendon. At this point, just get access. That's the biggest thing. But remember, if you start with femur and you go through and through or you miss, you no longer truly have distal or proximal tibia as an option.
Do you guys use the actual drill or do y'all manually put them in for like infants?
For us,
They're like in your experience.
I mean, in our experience, like, hospitals are different because hospitals, you'll have NMPs who are going to cut the cord and get access through the cord.
Gotcha, yeah.
So in a hospital, you will talk about an IO to an infant, and unless you're going to like Texas Children's downtown or Memorial Hermann downtown, most places will be like, you did what to the baby? Like, most of them will just use access through the cord. That central access, though, that's like a central catheter, a central IV, though. We don't have that option. So just get access any way you can. But most hospitals will use that. That's why If they can't get an IV, they just do that.
I was just asking because, you know, sometimes they're so small, you may not even have to like drill, you could just pop.
Yeah, sometimes, like, you don't even need to use the actual EZ-IO drill. You could just use the needle point and kind of shimmy it in. The old school non-electric version was called a jamshidi because you would jam it in. And then, like I said, the blue needle is a little bit longer. So just be very careful that as soon as you drill, as soon as you lose resistance, let go. Like, even if you're doing it manually, as soon as you stop feeling resistance, stop pushing. Because you're in the marrow. That's what you need. Any questions so far? Like we said, distal femur, go right above your kneecap. About one, for us, it'll be about 1 finger width, maybe a little bit more on your bigger infants. You can do slightly off center. So this is the baby's right foot, if you're looking, that's his big toe. So they're saying go slightly off to the center. And by slightly, I mean like, here's midline, and you're gonna go like right next to midline. And that's just to avoid the tendon. That's your distal femur option. The best option for anybody under 6. But also, if you have another option, you can do proximal tibia, about 1 finger breadth below your kneecap, and you're gonna go medial until you find that flat plane on your tibia, drill there. And that's what it'll look like. So like the baby's knee is right here, and you're just, here's the needle just off to the center. I was always taught not to aspirate an IO, especially on the infants. Their marrow is super thick. So if you try to aspirate, you will clot off the line that you have. So I was always taught just to flush it. Try to flush it with like 2 to 3 mLs. If it flushes good and you don't have any swelling at the back of the thigh or any swelling at the back of the calf, like losing my words, then you have a good line. You don't necessarily need to see it aspirate back for it to be a good line. And then, like I said, your only drugs for resuscitation are epi and normal saline. We already talked about normal saline being your volume expander. 10 mLs per kilo. Make your best guess at a weight. Hand tubby will also help you out there because hand tubby will say preemie is usually this weight or newborn is usually this weight. For epi, I did the doses off of what our protocol says for community. So this is not neonatal resuscitation standards code dose epi. This is community's code dose epi wave. Does everybody, I'm gonna let you guys all read this slide. But this is how you mix your epi for a neonate or for a pediatric patient. You're going to take your epi vial. You're going to take 1 ml of it, which is 1 milligram, right, from our vial. You're going to squirt out 1 ml of a saline syringe, and you're going to add that 1 ml to it. That is going to create your code dose syringe. That dose is an adult dose. That whole syringe is 1 milligram, right? That whole syringe is what we usually give an adult. Label that syringe. That syringe is not what you go and then push into your baby. Please. Put a stopcock on that syringe. Off of that syringe, you're going to add another syringe, and then you're going to pull your actual code doses for your baby. Your code dose is I don't even worry about this, 0.1 mLs per kilo. Remember how I said hand heavy is going to tell you the guesstimated weight of your preemie or newborn? It's going to say your baby's 2 kilos. 0.1 mLs per 2, that's going to make it 0.2 mLs. You're going to pull up 0.2 mLs from that 10 cc syringe. 0.2. That's like that much epi. And then you're going to hand that off to someone and use closed loop communication. Here's your 0.2 of epi. And then you say it back to me. I'm giving 0.2 of epi to the baby right now. Every 6 minutes, Just like community says, that's how often you'll give epi. Does anybody have any questions? Label your syringes. Don't accidentally give 1 full milligram of epi. That is a lot of epi.
That's happened.
It has happened, and it's easy to happen. And it's easy to happen because also, remember how I said a normal saline bolus for a 1 kilo kid is 10 mLs? Well, what if someone didn't label that epi syringe and it's in a normal saline syringe, and all of a sudden it's like, here's your volume expander, and your kid's heart rate goes up to like 240 or 280 or something way higher. You accidentally just gave 1 milligram of epi. Bad. Bad. Label, label, label. Carry a Sharpie and label. Any questions? Are you guys all pros now at resuscitating?
Thank you guys for coming today. I know we're talking about topics that make people uncomfortable, but we have to talk about these things because we deal with kids. The incidence of sick kids that we've been dealing with lately this year has gone up a lot. And then we recently had a drowning in our area a couple weeks ago, and we're going to review that case. So just kind of starting off with this first question, you know, how many do you think have occurred this year in Texas as far as drownings?
Too many.
Too many. One is too many. I checked this on 5/15 and we were at 18.
That's just Houston or all of Texas?
That's Texas. So we're just working our way into the heat and the summertime. So unfortunately that number will probably go up. We've had one in Fort Bend, which happened to be our territory. Okay, so we're going to review that case in a little bit, like I said. There have been 2 in Harris County. And how many do you think occurred in 2023?
54. 124.
Okay, 90. Okay, so a lot. And this is just talking about kids. I'm not including adults and those statistics as well that could also make this number go up. So 2 were in Fort Bend. I can't remember if that was in our area or not. You know, Fort Bend's a pretty big area. And then 25 were in Harris County. So I put this slide up here because it's not something we want to deal with, but it's something that very much could happen in our area. So I would rather you guys be thinking about how you're going to act in that situation versus just being caught off guard. So that's kind of the point of us going over this. What are some things that kind of make people more predisposed to drowning, adult or pediatrics?
Not knowing how to swim.
Not knowing how to swim. It's a big one. What else? Unsecured pool. Inebriation, right? Alcohol, drugs, weather. Good. So those are all different risk factors. So first one is going to be aged. You know, the younger they are, the less likely they are to be able to know how to swim. A lot of the times, if younger kids are drowning, it's because they weren't being watched or they snuck out of the house. Something of that manner is happening, and they ended up drowning because of that. So age is going to be a big thing. Males are more likely. Males are just riskier. They're doing things that being drunk, in the pool, who knows what it may be. They're just being riskier, so they're more likely to drown than a female will. People who can't swim, like Lauren said. If you can't swim, and you're an adult, Dr. Stevens said this in our last lecture, if you can't swim and you're an adult, you need to learn how to swim. Or don't go in water and try to relax in water and not know how to swim. You're just mixing things that are not going to possibly be very well for you. And then epilepsy. I remember I made a call where the girl had a seizure in the pool and the mom was able to pull her out of the pool, and I'm like, I don't think she should be swimming, right? Like just imagine if she didn't have somebody out there watching her and she sees in the pool, like, that's not a good thing, right? You don't want your kid who has seizures to be swimming in a pool, because what if they're underwater and they have a seizure? Like, they're just going to swallow all that water. So epilepsy is definitely a risk factor. Sean mentioned intoxication, you know. And we all like to have a little drink by the pool, relax a little bit. But trying to swim in a river when you're super intoxicated or a pool may not be the best idea. Hopefully you have people who are watching you and making sure you're not going to possibly drown or tip over. I've heard some stories here about people in a river, so Exhaustion. So this could be people who are just tired from just swimming in general. If you happen to work an event where they're doing a marathon, so like the Ironman is something that happens around Houston, and people in Ironman are doing very long miles of swimming, they could get really tired and be out in the middle of a lake or an ocean and possibly drown. So those are all, exhaustion could play a factor into this. So when we talk about drowning itself, whatever may cause that person to drown, the first thing that's normally going to happen is that you're going to start swallowing water. As you start swallowing water and you start going underneath, your body's natural reaction should be to hold their breath, right? But you can only hold your breath for so long. And then when you're not able to hold your breath anymore, what do you think happens? You gas, and that air comes in. There's like a low percentage of people that do spasm, and the spasming may help prevent water from completely coming in. But again, if somebody doesn't get you in time out of the water, that's only going to last for so long, and eventually all that water is going to come in. What are some other things that we have to consider besides the obvious? So we obviously know drownings could cause a lot of fluid in the lungs, it could lead to respiratory arrest and cardiac arrest. But what are some other things that you might want to consider if you're coming upon a pool, if the weather? What are some things that we have to think about as well that could be additional injuries? Like hypothermia, right? So if they're in a pool and it's cool outside, or they've just been in the pool for a long time, they could become hypothermic from that, depending on the temperature of the pool. Say it. Somebody say it. Electrocutions is one. Huh?
If you dive and you hit
You're good, right? So head injuries. How shallow are they actually into the pool? Chemicals, right? So those things that you have to think about. So obviously, having a bunch of fluid in your alveoli and filling that up is going to prevent gas exchange. And if you can't exchange gas, again, you're going to go into respiratory arrest and then cardiac arrest. So initially, if you do happen to get somebody that was just pulled out of a pool, or you guys had to pull somebody out of a pool and you're bagging them, you may not get a lot of chest rise because there's so much fluid in those alveoli. It may take a couple breaths to get that fluid kind of moved out of the alveoli so that you can adequately ventilate them. So you might have a little bit of resistance when you're squeezing that BVM initially. So when we're talking about initial management, if somebody gets pulled out of the water and they're breathing on their own and they have a pulse, put them in a recovery position, and then obviously start looking at their airway, seeing if there's anything that you need to suction out of their airway. If they're breathing on their own, obviously getting oxygen on them right away is going to be a big thing. But if you pull somebody out and they're not breathing, so say they're in respiratory arrest, what is the first thing as an EMT you would do? If they're not breathing, what are we going to
Breathe for them.
You're going to breathe for them, right? You're going to start ventilating for them. You're going to use airway adjuncts. You're going to position them. If you have multiple providers, what's the most effective way to ventilate somebody? Two-person seal. So you're going to provide a two-person seal. And then we're hoping that as we give rescue breaths, we start displacing some of that fluid. It gets enough to where we're able to get enough oxygen to the brain that maybe they'll wake up. And if they wake up and they still have pulmonary edema and they're able to follow commands, what can we do? BiPAP, CPAP, right? Now, if we're talking about kids specifically, I don't know if we have a small enough mask to do that. And that's the unfortunate part, is we just don't maybe have a small enough mask for a child. But if you do have a small mask, which everybody should have different size masks on their units, I walk in some of y'all's units and just check, and sometimes we're not always stocking them. So make sure that your ambulances have the normal size, which is medium, and a large. If you don't, you need to talk to Shark if they're not in the vending machine. Okay, but hopefully we can get a small mask on and provide CPAP or BiPAP. But if they don't, their spontaneous respirations never improve, what route do you think we're going down? We're going to have to intubate, okay? And that's just what we're going to have to do to better manage their airway. What is something that we might want to add on to a BVM or titrate on a vent? PEEP, right? And how is PEEP going to help in this situation?
Pushes out the fluid.
Helps push out fluid, helps oxygenate better. You have a question?
Could you nebulize some Atrovent to dry out the lungs?
You could. I don't think it's going to hurt. It could offer some benefit, especially if you're on CPAP or BiPAP.
Right, that's what.
Atrovent, when you look at it, it's indicated for drownings. So that could be definitely something that you could do, and that's been in the EMT basic scope of practice even before we added Atrovent into the wheezing scope of practice for the basics. So yeah. Any other questions? No? Okay. So advanced airways should be placed early as possible, especially if their spontaneous respirations are not improving. You will probably have, not only did they swallow some fluid probably into their actual stomach, their lungs, they could also have some fluid into their stomach, so that could lead to gastric distension. How do you think that affects their ability to be able to get a good tidal volume? Exactly, and that's especially important in a kid. Any kid could have gastric distension, with just normal BVM ventilations due to air filling up into the stomach. So even if it's not a drowning situation, you might want to consider putting an OG tube down a kid. But for any adult or pediatric patient who drowns, that's probably something that you should do immediately after you place an advanced airway, is to put an OG tube down them. And it also will reduce the risk of aspiration, because if your stomach starts filling up with contents and they start vomiting, that's also going to lead to a lot of issues as well. Place them on the vent and then prioritize, obviously, oxygenating. And we just said that PEEP is the maneuver that we're going to use to help oxygenate. And then what's the other part of oxygenation? FiO2. So increasing the percentage of oxygen and then the amount of PEEP. So the case study I'm going to talk about, I left out names. I got their approval to use it. We're going to talk about what went well, but we're also going to talk about what didn't go well, just so that we can all learn from the situation. We all know that calls don't always go how we would like them. I think at the end of the day, the crew did everything they could to manage this kid. So just kind of starting off, it was a 1-year-old found supine on the back of the porch, family members providing CPR. So a little background. The kid crawled through the actual dog door, ended up into the jacuzzi. They found the kid at the bottom of the jacuzzi. They don't know the time frame of how long the kid had been out there. So the dad followed instructions from dispatch, got the kid out, listened, was calm enough to provide CPR. The family did a good job. The rest of the family did a good job of just staying out of the way. And the dad was the only one that made contact with the EMS crew, and he remained calm the entire time. Obviously, everybody else in the family was pretty distraught. So I want you guys to pull out hands heavy, okay? I want you guys to tell me, you're dispatched to this 1-year-old drowning, and it comes in as a cardiac arrest. What are some things that you're going to prioritize in wanting to know and writing down? What are some things that you want to communicate with your partner? And then I want you guys to think about how you're going to transport this patient. And then where we're going to transport. Because those are all questions that we have to figure out in the heat of the moment. Please tell me what you are wanting to know or write down as you're going into this call for this 1-year-old.
Probably blade sizes, just doing intubation, equipment-wise, what the vitals should be, and atropine dosage.
Okay, Atrovent. Okay, what else? Epidose.
Epidose, yeah.
Okay, anything else anybody else would want to add in?
Just everything we possibly need for CPR.
Good, okay. So this is probably one if, let's say me and Max are partners. Max is my EMT, he's driving. Hey Max, we're going to use an iGel size 1. We're going to be giving this much epi. We already know the IO needle size, but I'm just going to say it out loud. I want to know the size 2. And then what did Lauren teach in her lecture? We always want to know what the tube that's appropriate, and then we probably want how many different tube sizes? Size up, size down, right? It may be helpful to say, hey, we're not going to be able to use a bougie because this kid is 1 year old. He falls within the range of using a stylet. That might be helpful just to remember that, while we're not actually in front of the patient and trying to figure it out. So we're making sure that we're prepared going into the call. And I might just talk it out with Max, like, hey man, if we get there, I want you to start compressions, okay? As you're starting compressions, I'm immediately going to put an OPA in and start BVM ventilations, suction the airway if I need to, okay? When the next crew comes in, fire crew, hey, I want you guys to take over compressions. Max, you're going to jump to airway. I'm going to get the pads on the kid, okay? After we get pads on the kid, we're going to do a quick pulse rhythm check. What is something that we probably want to know before we do a pulse and rhythm check?
Defibrillation.
Right? So that's something that nobody said. So now you're like, shit, what do I shock him at? So now there's just whole delay in that. So make sure you're writing down the joules that it's supposed to be for this kid. Okay? So after I do a pulse check, rhythm check, let's say the kid's in asystole, we go back to CPR. What's my next move? What do we need? We need access, right? So where are we going to get access at? Distal femur, okay. So I'm going to drill the kid. I'm going to get distal femur IO access, and then how am I mixing my epi, and what am I using to draw up my epi? Good.
Put a stopcock on it and put another syringe on there to draw it out.
Good, right? So I'm drawing my adult cardiac arrest dose. I'm using my stopcock, and then I'm grabbing a syringe. I'm drawing up my first adult cardiac arrest dose, okay? I'm pushing it through my IO, and I'm flushing it. So we got some good stuff going on so far, all right? If I'm doing OPA and BVM ventilations, okay, what is something else that we could put in that's considered an advanced airway? iGel, right? So we could throw in an iGel, and then what do we want on top of the iGel? End-tidal, all right? Secure the iGel. People forget to secure the iGels. Do the iGels have a cuff?
No.
No. So if you don't secure your iGel, the iGel could be moving around, and if the iGel is moving around, it may not be able to provide an effective seal. Have any of you guys tried to secure an iGel size 1? No, right? A lot of us haven't. It doesn't have the little tabs on the side. Okay? So if any of you guys ever secured the iGel where the actual hole where the BVM sticks on, you're just taking the straps and putting it over into the hole. If you guys don't understand what I mean by that, let's talk about it after the class and I can show you. One thing that the crew realized with the iGel was it didn't come with a strap. Okay? You're going to have to probably grab a strap from another iGel. I don't know why that is. That's probably something I need to write down to talk to Shark about. You know, why they don't come with straps. But I'm just kind of bringing up points because you don't realize those things until you're in the moment. All right, so I kind of went through some of this stuff. No last seen normal. They're cold, they're pale, they're cyanotic to the lips and hands. So what are we prioritizing in this kid?
Airway compressions.
Airway and compressions, okay. I don't know if you heard, my sequence is a little bit different than it would be for adult cardiac arrest. Adult cardiac arrest, we're trying to get the AED on right away. And why is that?
Most of them are cardiac related.
Most of them are cardiac related. In my sequence, it's CPR, respiratory. Once I get more hands, somebody take over respiratory. Preferably for me, I trust my EMT. Okay? That's why I had Max jump on the airway, because I trust him. It doesn't mean I don't trust the firefighters, but we all know nights and weekends, we're not working with people who are EMTs on the engine, right? And we know that that's probably the most important job besides CPR is somebody managing the airway. I want somebody that we trust, that we train to manage that. And then I went to putting on the actual pads. How are we putting on the pads in a kid? Anterior, posterior. If you guys haven't practiced it in a while, practice disconnecting the adult pads and connecting the PD pads. It sounds simple, but people do struggle with that. If you're in the middle of trying to put it on for a kid and you can't get it off because you haven't done it in a while, that's going to add panic to you. We already talked about where you're going to get access. You guys already know how much epi you are going to give, how much you're going to draw up. And then what was the size blade for this kid?
1
1 Mac or 1 Miller, right? So we want to... Now, not everybody's airways bag is set up. So I have a bunch of people who are on shift today. How many people have direct blades in their bag? In their actual airway roll that we take into the house?
We have the pediatric roll.
Yeah, we have the roll on the truck.
Okay, so I was about to bring up that point.
On the truck.
On the truck. So if you're going to a pediatric cardiac arrest, your adrenaline's kicking, but I want you guys to think about this now. If I go to one, what do I need to grab? So we're not having to ask somebody to run out to the vehicle. Bring your roll in. That way it has all your different size blades inside of there. Okay, remember that. One of the things that nobody mentioned was suction. How many of you guys are carrying the correct suction on your actual suction kit? Right? We don't probably have the correct soft tip suction. So I might grab that as well as something that I'm grabbing as I'm taking into the call. So I'm not having to send somebody out who doesn't know how our ambulance is set up, trying to figure that out. Does that make sense? And then what was the size tube? 3.5 or 4? Okay. Can you use a pediatric bougie on a 402?
Yes.
Too small.
4 or less.
You can on a 4. It's going to be
like super snug.
it's going to be snug, but you can still slide a tube over. Yep.
Let's style it on 4.
Yep. Style it on a 4 or less. Okay.
You just
that's,
have to make sure somebody's holding the tube, or you're holding the tube really well when you go to pull the stylet out.
Cool. All right. So first attempt, I did a tibia IO. They missed on the tibia IO. Distal femur IO was good. They gave 0.1 milligrams of epi. They did all the normal basic stuff. So they put an iGel in right away. They had CPR going on. They got epi on board, and then I think they moved the kid to the back of the ambulance. That's where they did their first intubation attempt. Some of the things that they realized with the call was CPR was not effective. A lot of the firefighters had never done CPR on a 1-year-old. So how would we do CPR on a 1-year-old? Good. Okay, everybody's doing this. Sometimes people forget that. Sometimes you're so focused on your job, you're not realizing that the engine is not providing adequate CPR. So I need you guys to be mindful of that, because if we can't do CPR effectively, what's the point of doing everything else, right? So we got to make sure we're doing good CPR. Do our pulse checks change at all? Right, we're still doing 2-minute cycles. I prefer you guys to pre-charge the monitor. They're less likely to be in a shockable rhythm, but I'd rather you guys be prepared than not be, because you just never know. So they get in the back, they did intubate. They had difficulty getting the stylet to work. The stylet kept curling up on them. So they had a great view of the vocal cords. They were using a McGrath. They used a McGrath size 1. They had a great view of the vocal cords, but the stylet kept curling up on them. So they said, hand me a bougie. They got a pediatric bougie in through the vocal cords, but then they're trying to put the 3.5 tube over the bougie, and what happens? You can't do it right, so shit, take the 3.5 off. I'm not sure if they were prepared with additional tubes, but this is where preparation is key. They did get a 4.0 tube and slide the 4.0 tube over, and they intubated the kid with a 4.0 cuff tube. So they got the kid successfully intubated. Obviously, like I said, calls don't go as smooth as we would like them, but these are good topics to bring up because I want you guys to think about this stuff because it does happen in real time. We just forget these minor details of tube sizes and things of that nature. If you guys have not intubated a pediatric mannequin, please come by the training center. We can always do that. June 28th, we will be doing an RSI class, and we will have hands-on scenarios or skills like we normally have in the past where we have a PD station set up. So please come by and do that so you can practice taping the tube, practice curving your stylet. Stylets are very flimsy, and if you're not used to using them, they can be a little frustrating to use. So,
Was it hot outside too? Was it hot outside too?
It was hot outside.
So if it's hot outside, it makes if your tubes have been sitting outside, it makes the tubes really flimsy. So even with the stylet, sometimes that's why it'll curl every time you try to intubate, is because the tube itself is super malleable at that point, and even with the stylet, it's just not enough structure. So if it's hot outside, try to keep. I mean, it's hard because we're always outside, but
Yeah.
the longer your tubes sit outside, the more flimsy they're going to get, even with a stylet.
And I did ask. I asked the in charge, hey, did you try to shape the tube like Lauren was saying? He said he did. It just was flimsy, but they did get the patient intubated. And what hospital would you go to, and how would you get this kid to the hospital?
I think about flying.
Okay, flying is definitely reasonable. You could fly the kid. Anybody else have any?
They probably need Texas Children's downtown or Med TMC.
Yeah, I think
A downtown.
yeah, it's not wrong to think about flying. It's not wrong about thinking them taken to the med center. I think Stevens is okay with going to the closest children's hospital. So
Especially if you don't have Ross.
yeah, if you don't have Rosk and his CPR in progress, you could drive them to TCH West. Now, obviously, if you did get Rosk, then now you're going downtown. And if you had life flight en route and you got ROSC, then that makes your life a lot easier because now you're not having to manage a post-ROSC drowning. But those are decisions you just have to make in the moment, but know it's okay to go to TCH West. If you get ROSC, you prefer to go downtown, but if it doesn't make sense to fly because you didn't ask for it initially, TCH West should be able to stabilize the kid. And they can use specialized transport like Kangaroo Crew to get the kid out. So that's an option that you can use. Any questions about that?
I mean, I guess I'm just asking, what would you do as far as transporting ground or calling line?
I would gauge it based off of time of day, day of the week, and then I would probably ask for an ETA of life flight because you don't know how far out they are. If they tell me they're 20 minutes out, then I'm probably just going to go to TCH West because I'm going to do my initial resuscitation on scene and then start moving towards the ambulance and start transporting. There's no like definitive answer for it. Whenever somebody asks me, when do you fly somebody in general, it's you taking in all those factors into consideration.
Yeah.
Like you're not going to be wrong for calling life flight.
For CPR in progress on a kid, we're never gonna call it, right? So like, I don't know, for CPR, like I would probably call life flight.
Yeah.
They can continue and get there quicker than we can.
Yeah,
But
just
like-
make it simple on yourself. Just call life flight. You know.
But if you get ROSC, then, I mean, it's kind of up to you. You could still call even after ROSC.
Yeah, it's not going to hurt.
Yeah.
You know.
Yeah, just like, you're just working an arrest.
Yeah, I mean.
You mean in the back of the truck?
Yeah.
It's just hands, and you need a lot more hands. And the other thing with, if you're CPR in progress, the reason I would fly is that's like a 5 to 7 minute flight, and they get to where they need to be a lot quicker. Whereas for us, no matter, like Tate said, time of day and where you're at, like a 7 minute flight versus 20 minutes on the road sometimes, and even going lights and sirens, people aren't going to move. So then if you're intubated, now you need to worry about a bunch of people, a bunch of hands on a very small patient with not a lot of room on the patient and on a bumpy road. Like it's going to be super easy to accidentally extubate a patient or something else happens. So
I think flying is probably going to be the safest option. But that's why the ETA plays into part of it. I mean, if they're really far away, you kind of have to make decisions,
Yeah.
you know. Cool. All right. Any questions about drownings? Okay. Anything that maybe I didn't hit on, you guys have questions about? It's run like a cardiac arrest, but you have things different. It's more like it's respiratory driven, but there's a situation around it that is different than what our normal medical arrests are. So we just have to take those factors into consideration. Is there anything, questions, comments? If y'all need to go over any specific equipment after class, I can go over that with you. So this year, for whatever reason, we've had a lot of kids with trachs. How many of you guys have made a kid with a trach this year? Okay, got a couple hands going up. And I don't remember off the top of my head, but we've had like 4 or 5 PD arrests. The majority of them have had a trach. One of them was a drowning. And I want to say every other, the one we had a trach, right? The kid?
No, he
He
didn't have a trach.
Okay. So majority of them have had trachs. And if they haven't been in arrest, we've had one for sure that we're going to go over here in a little bit that was almost in cardiac arrest from issues from his trach. So I really want to go over this. We also have adult patients that have trachs that are sitting inside group homes and nursing homes and stuff like that. And I don't claim to be an expert on this, but I would do my best to provide education for you guys. So the outer cannula is what's actually providing structure to the actual trach. And not every trach is cuffed or uncuffed. So when we're talking about trying to figure out what's going on with a patient who has a trach, one of the questions I want you guys to ask is, do they have a cuff or uncuffed trach? Why do you think that's important? Yeah, so in order to provide effective positive pressure ventilation, you really need a cuff tube. Okay? If it's uncuffed, and we'll talk about how to trial and error things, if it's uncuffed and you're having difficulty with a patient who is trached, you might have to replace it with a cuffed. And that's something I'll explain in a couple later slides.
Most patients who are at home and live with a trach are usually uncuffed because the cuff itself could cause trauma and could cause ischemia and necrosis. So a lot of the times kids long-term or adults long-term are not necessarily always on cuffed trachs. So that's just something that you have to think about. The inner cannula, that's something that can be removed. This is typically what is going to get clogged. If you do have a really big, thick secretion or mucus, this is typically what you're putting your soft suction catheter down and trying to remove that. But if you have such a thick secretion or obstruction, they should have a backup inner cannula that you can put in. But this is typically what you're suctioning. Then the arbitrator is not necessarily left into the trach. It's what's typically put in the inside of the trach to help facilitate putting it in. It's a soft tip. It's soft. It usually sticks out the end of the hole, and it just makes it easier for you to get for them to put the trach in. But they take it out so that they can breathe, because they couldn't breathe with that on if they left that in. The inner cannula is needed to hook onto a BVM. So you have to have the inner cannula in for a BVM to actually hook onto it. I see some faces, you guys kind of like, ugh, because nobody likes dealing with trachs. Nobody likes suctioning them. But obviously if you show up and they're in respiratory distress, one of the first things you guys will probably need to rule out is what? Obstruction. So we're going to have to suction it. Does anybody have questions about how this is broken down? No? Cool? Okay, let me keep moving on then. Things you have to know, questions that you want to ask. Hopefully there's somebody who's competent is able to answer. Now, if it's a kid, Lauren can probably attest to this, they train the parents to be very proficient at managing and caring for those kids. That is going to be your best friend. Okay, those are the people that you want to ask questions to. If we're showing up to a group home, okay, they may not be the most educated, even though we think they should be, but they may not give you all the information that you need. But questions that I want you to ask. Size of the trach. Why do you think that's important? So if they're a size 4 trach, I'm just throwing out a number, that correlates to an ET tube of 4. So if we had to replace the trach because it's uncuffed and there's too much leakage and we're squeezing a BVM and they're not getting better, okay, you might have to replace it. And I'll talk about that in a little bit. They should always have an emergency trach, a backup, usually a size smaller. So if you're having difficulty with one, they should have a backup that they can use. So size is going to be very important. Cuffed or uncuffed, I've already talked about that. And then reason, why were they trached? Okay, that's important for me because when we go down this stepwise process of what to do, you get to a point where you're having to decide to either put in a new trach, which Dr. Stevens prefers, like a new tube, or if you're going to intubate the patient. What if you're going in and intubating somebody who has a mass or something that you aren't going to be able to intubate? So that's not even an option for you. So you kind of want to know why they have a trach. That's important. Do they have a backup one? And why did I say having a backup one is important to know? In case you need to replace it, you already have something that is sized appropriate for them. Any questions about any of these so far? No? All right, false passage. Do you have a question, Sean?
No.
Okay. What is false passage?
You're not in the airway, but you feel like you're in the airway?
Yep. You're not in the airway, but you feel like you're in the airway. So could that be a potential issue with somebody who has a trach at home, is that it's no longer in the airway anymore?
Yeah.
For sure, okay. So what are some steps, or what are you guys looking for if somebody's trach is in a false passage?
Dropping the 2 stats.
So they're going to they're hypoxic despite you providing oxygen. What is something you might feel with a BVM? Resistance, okay. What is something you might see in end tidal? You won't have an end tidal. So quick dirty way is you're providing, you get oxygen on them, you're squeezing the BVM, you're hitting resistance, there's no end tidal, they're still hypoxic, you suction them, you're not getting anything out, okay. Your mind should be immediately going, all right, this trach is probably in a bad spot. Cool, so no end tidal, resistance, and then you might get subcutaneous emphysema along with some of those things. Do you guys know what that is? Right, so as you're squeezing the BVM, you're noticing that this is a really bad case. Obviously, I hope you guys recognize that subcutaneous emphysema has set in and not continue to ventilate somebody. I don't know what's happening in this case. I got it off the internet, but you can see how much subcutaneous air has built up in this patient, and it's not good. So that's something you would want to recognize very early on. If we did come to a conclusion that this trach is in a false passage, how would you guys go about putting in a new one? Somebody say something? Good, right? So if you're you have two options. You could either use their backup one, take out the old one, put the backup one in the hole, okay? Try to ventilate through that. Or you could use a bougie. So it's a size 4 trach, and take a pediatric bougie, put it down the hole, and then grab the tube, the ET tube, size 4 ET tube, slide it over the bougie. How far should you go past the actual hole?
Just until you can't see the cuff anymore?
Yep, just take the cuff, just pass, right? Because we don't want to right main stem them. Take out the bougie, get end tidal BVM on, inflate it, and then hopefully you have end tidal and chest rise, and you just solved the issue. Does that make sense? A lot of you guys are like, shit, I hope I never get in that situation. But we have to talk about those things. So I want you guys to kind of start off, have this in your head. All right, we show up, they're in distress. I want you immediately to apply oxygen onto them, okay? Insert a suction catheter, try to suction it. If you're not getting anything out, consider removing the inner cannula. Remove it out. If it's thick, nasty, bunch of gunk inside of it, hopefully you've already asked if they have a second inner cannula. If they do, take that one out. Put a new inner cannula in, ventilate with end tidal, oxygen, BVM, and hopefully your issues have been solved there. If they do have a cuff, consider deflating the cuff, reinflating it again. If you're still having issues, there may be a chance that the cuff is possibly popped, something of that nature. And then if you're going through all these things and the patient's not getting better, consider removing the trach. Okay? If you remove the trach, what are something that you can do while you're getting set up with another tube or another bougie, something that a basic could do very easily? You can bag, right? And if it's an adult patient, what size BVM would you use, or the mask?
A PD.
You would use a PD, okay? If it's a pediatric patient, you can still use a pediatric mask. You would cover the hole. If you decided for whatever reason to ventilate the mouth, what should you do while you're ventilating? Cover the hole, okay? If you're squeezing and not covering the hole, what's that? Okay. If you decided to put an IJO in, you guys remove the trach, you're having difficulty getting a new one back in, and you put an IJO in, and you're ventilating, what should you do?
Cover the hole.
Cover the hole. If you intubate, if you decide to intubate because you can't get a new trach in for whatever reason, what do you do while you're squeezing the BVM? Cover the hole. Okay? So this is kind of what it looks like. So on a baby. Steven says he has never seen the picture on the left. Have you ever seen them do this in the hospital? Put like an LMA over the hole?
No.
Okay.
Also, though, theoretically, nurses aren't allowed to put an LMA in, so half of them don't even know what an LMA
Gotcha.
is.
But we don't have LMA, so this probably isn't the best picture that I grabbed. But I saw some stuff online where you could put like an LMA over the hole and ventilate. I don't know how effective that is, so just kind of ignore that. And then, like I said, if you can't get a new trach in and nothing else is working, then intubate. So your tube is going to, the cuff of the tube will probably go just down past the hole itself, and then you can inflate it. So you're still able to provide some positive pressure ventilation. If it's just above the hole, you just have to kind of cover it. That way you don't have any air leaking out as you're ventilating them.